As the life sciences industry grows, it does so thanks to innovation, its people, and its amazing partnerships. I'm DePaul Elliott-Tomby, President of Alliance Consulting Engineers and SCbio board member. I believe that partnerships are the cornerstone of improving health and healthcare for all citizens during and after the pandemic. COVID has drawn attention to existing long-standing racial and ethnic health disparities in South Carolina and across America, providing an opportunity for us to work together and to come together. South Carolina Hospital Association President, CEO, my friend for over 20 years, Thornton Kirby, will lead our next feature panel of state and national leaders, including Dr. Marjorie Jenkins, Dean of the School of Medicine, Courtney Christian, Pharma Executive and Director of Black Women's Health Imperative, and Dr. Harris Pastides, Chair of the South Carolina Institute of Medicine and Public Health and President of the University of South Carolina, who I've known for almost 20 years. Their contributions and ideas will no doubt help us understand how the power of partnerships is essential to achieving a better tomorrow for us all.
Thank you, DePaul. We are looking forward to this panel, and I appreciate the introduction. It's my pleasure today to facilitate a panel of three distinguished experts who know this issue and this state well, and I want to introduce them briefly, and then we'll jump right into our panel. The first is Dr. Marjorie Jenkins, on your bottom right there. Marjorie is the Dean of the USC School of Medicine in Greenville, and she's the Chief Academic Officer for Prisma Health Upstate. Marjorie, before this role, has held a number of leadership roles, as the others have as well. She's worked with the U.S. Food and Drug Administration, Office of Women's Health. She has been a professor of medicine at Texas Tech University, and she was director of the research program for health professions master's students at Johns Hopkins University. She's got a really diverse background, and she's an expert in health issues related to sex and gender, and her opinions are frequently sought on women's health issues. Courtney Christian, on your top left, is the Senior Director of Policy and Research at Pharma. She focuses on state-based reforms that are impacting health insurance, prescription drug coverage, and public health programs, and health equity. Prior to joining Pharma, Courtney worked as Director of Policy and Advocacy for the Black Women's Health Imperative in Washington, and she also has served on Capitol Hill in several roles, including as a legislative director, which we all know is a significant leadership role. And then on your bottom left is Dr. Harris Pastides, who is the Distinguished President Emeritus at the University of South Carolina. He served as U of SC's 28th president from 2008 to 2019. And prior to serving as president there, he was vice president for research and health sciences and dean of the Arnold School of Public Health, which many of you are probably familiar with. Before taking on leadership roles, Dr. Pastides was a professor of epidemiology and biostatistics at the University of Massachusetts. He's had many leadership roles with the Southeastern Conference as president of the NCAA, and he's currently the only non-physician on the board of the American Medical Association, representing our state there. So I'm delighted to have these panelists with us. They're very well experienced in many of the issues we're going to discuss. So why are we meeting today? Why this panel? Our purpose today is to really explore the value of partnerships and their potential to improve health for all South Carolinians, particularly underrepresented populations. So I'm just going to give a couple of observations of my experiences with partnerships, and then we'll jump right into the panel and ask about their own examples. So I'm the president and CEO of the South Carolina Hospital Association. As you might imagine, the last 10 months have been busy for our members, the hospitals. We have partnered extensively with many state agencies, none more so than the Department of Health and Environmental Control. So the Hospital Association and DHEC really have partnered in a way you would not normally expect from a regulator and its regulated industry. But essentially, we have made sure that all patients who need to be in hospitals have capacity, that we test people in all corners of the state, and now that we are vaccinating people all over the state. So that partnership has really driven a response, I think, that would not have been possible if the two didn't work together. The Hospital Association also works with SCbio, and we are exploring more and more opportunities to find new and innovative approaches from the life sciences industry, and so that we can apply them for the benefit of our patients at the bedside. That's just another example of a partnership that has been really robust and rich for our state. The one that I want to use as a transition is from my experience when I worked in the administration at Clemson University, and when I first met President Pastides, I got to see firsthand how the research universities in the state, when they partnered together, really changed the conversation in the elected arenas, the General Assembly, the governor's office, and other spots, because it's not always expected that Clemson and USC and the medical university will agree on everything. And when they do agree and bring forth an agenda together, it really resonates. So those are some places I've seen the partnerships. I'm going to let that be a transition to Harris. President Pastides, you have seen many of these as well. Would you comment on your observations on the power of partnerships?
Yes, absolutely. And good morning and good day to everybody at this very important day for SCbio and for South Carolina. Let me first say that, both competition and cooperation are natural forces. They're natural to individuals and natural to organizations. But I do believe there have been great examples within our state and between the research universities where we can not obviate, not deny the natural inclination to compete, but you can also cooperate. There's a neologism called coopetition. I don't know if it's in the Oxford English Dictionary yet, but that's really what I'm talking about. And I think the most prominent example during my time was the Endowed Chairs program, where Clemson, USC, and MUSC came together to compete, if you will, for funds from the Department of Commerce and the state to identify and recruit endowed chairs, often in the biomedical biotech arena. But we were given more points, if you will, if we collaborated with one or both of the other universities. So it was incentivized, if you will. So denying the competitive spirit is not an easy thing. And I think we need to think of ways to incentivize it. We can always say that, well, you'll be more successful that way, but that may not be quite the incentive enough. And so, if you're in the private sector, if you're in the government sector, I think we need to think of ways to incentivize that. So Dr. Martin Morad is one example. We have others, including at the USC School of Medicine, Greenville, but Dr. Morad was recruited by all three research universities. We got him from Georgetown University Medical Center. He's working on a biological pacemaker. So one day, if you have a heart attack, he'll be able to take stem cells from your skin, derived from the skin, but create beating heart cells, inject them back into the ailing heart, and restore heart function. Now, we're not there quite yet, but wouldn't it be great if that biological pacemaker is someday known as the South Carolina pacemaker? That could never have been done by one university alone.
That's well said. Your description of coopetition, Harris, reminds me of a Low Country story or metaphor, which is the crab in the bucket phenomenon. I don't know if you've ever heard of that, but when you put a bunch of crabs in the bucket, as soon as one starts to get out, the others pull it back down. And I want to thank you and commend you for the fact that during your tenure, we made sure we didn't play that game. We made sure this state elevated by working with everyone's strengths. So thank you for that. Courtney, your pharma experience during this pandemic must have been very interesting. Tell us what you've seen with respect to partnerships.
Certainly. Well, good morning, everyone, and thank you to SCbio for having me. I'm delighted to join in this conversation on the power of partnership. I think there is definitely power in collaboration of all of us speaking here today, and certainly between bio and pharma, especially in light of the last year. I think you alluded to 2020 being a year of historic proportions, right? Bringing with it sort of this once in a lifetime global pandemic, the likes of which hopefully we'll never see again. But it really brought our nation to a standstill, and it with its spread and with its high infection rate, and its impact on communities of color in particular. But I think that what we saw this year in this unprecedented moment is that our biopharmaceutical industry really sprang into action, right? We came together as companies across the industry to really look for and solve for the problem of our time, trying to find this vaccine and a return to normalcy. And so I think that the strength and innovation of our industry has been on display, but also that of our larger healthcare ecosystem, right? Hospitals and life sciences and our industry really had to band together in this moment and kind of put aside, those feelings of competition and participate and cooperate with each other. And so I think that that's something that will carry us forward in the future for some time to come.
Thank you for sharing that. And thank you for all of your industry's work to get this vaccine to market in record time. We are all very grateful and look forward to more coming online. Dr. Jenkins, you have had your own experiences in many arenas with partnerships. Tell us about your observations.
Yes, thank you, Thornton. And I want to thank SCbio for inviting me to be on this esteemed panel with my colleagues. I'll start with why I'm here in South Carolina. I've been here a couple of years. It is because of a partnership with Greenville Health System, now Prisma Health, who partnered with the University of South Carolina to create a medical school in the upstate. And part of that was to address a need for physician shortages in South Carolina. And so really growing up new physicians that train in a very complex environment embedded in the healthcare delivery system. I was at FDA for several years, and in watching the evolution of the past 10, 11 months of this pandemic, where globally countries, companies, pharma really banded together, right, to share the viral genome, to really create vaccines. Why do we have 5 to 10 vaccines in the pipeline, 2 already approved in the US? That is a maximum, representation of partnership. I think the government entities who came together with private industries to create Operation Warp Speed. We will never, hopefully we'll see it again in our lifetime in this sort of rapidly evolving science, but 10 months to a very efficacious and safe vaccine is fairly unheard of. So we have a lot of those partnerships. And lastly, I'll just say that University of South Carolina was one of the top 5 universities in creating their own salivary testing, bringing their students back in a safe environment and partnering with Nephron in order to do so. So there's just been really the best of partnerships, I think, that we've seen in the pandemic. Thank you.
Sure, thank you. Those are great observations from all, and I think they reinforce what Sam Konduras told us he wanted us to emphasize, and that is he believed all of us have seen that power of partnership, and of course you just demonstrated or illustrated how we have. So let's talk about COVID-19 for a minute. All of us have referenced that 2020 will be remembered for a pandemic, the social justice movement, and for polarized politics. It was a very tumultuous year. When we prepared for this panel, Dr. Jenkins said the pandemic has revealed the best and worst of our nation's healthcare system. Marjorie, would you care to elaborate on that observation?
I certainly would. I think at the beginning of the pandemic, where we didn't know much about the novel coronavirus, there was a lot of fear, and yet our healthcare workers really stepped up. Our first responders continued to work. Really, we didn't know it as much about the transmission of the virus. Was it aerosolized? Was it bloodborne? How did that work? And yet these people went in and worked countless hours and shifts and days, some without PPE, right? We had a PPE shortage. They put their lives at stake. Thousands of healthcare workers, frontline workers, have lost their lives in the pandemic, but many millions have continued to go in to save lives. I said, Thornton, about the worst of what we've seen in the worst of our healthcare delivery system is really in parallel to the social injustices that really came to the forefront last year and continue. And that is healthcare access, that is implicit bias in access for people of color, and also for those that were sent home time and time and time again. And we had higher death rates, markedly higher death rates than one would expect in certain populations. So marginalized populations, that really was expanded during the pandemic. And that's a systemic problem that we have to continue to address. Thank you.
Thank you. Let me open it up to Harris and Courtney. Comments on that or follow on?
Yeah,
No,
Go ahead,
Courtney,
Courtney,
go
and then
ahead.
we'll go to Harris.
I would just say I would absolutely agree. You know, in the midst of so much loss last year, we were really contending with this longstanding, enduring legacy of racism in our country, with the murder of George Floyd and Breonna Taylor, so many before them and so many after them, frankly, that still continue. And so I think these events really contributed to this sort of imperfect storm. I don't think it's perfect. It was an imperfect storm that really brought together sort of our collective anxiety in protecting ourselves from this unseen virus, but also brought up this collective anxiety and really specific lens on social justice issues that we haven't, in a way that we haven't talked about before. And it's a conversation that I think is one that stands to continue. So I think Dr. Jenkins is absolutely right. COVID-19 has laid bare the long-standing health disparities and gaps, and we have a real opportunity moving forward to work together in partnership, the power of partnership, to make sure that we can find ways to close those gaps in the future.
That's well said. Harris.
Well, I could say ditto and ditto, but I've got to earn my keep.
Yes.
But let me say, Thornton, at the outset, you mentioned three social dynamics that were pervasive in 2020 and continue, and that is social injustice, political divisiveness, and of course the COVID-19. I would argue they're not separate. They are one dynamic, all of which have worked together to impede public health's ability, if you will, to do an even better job. Although I'm a hopeful person, I've started documenting, if you will, the good, the bad, and the ugly about our approach to COVID-19, especially at a federal and even at a global level, because I'm not convinced we will automatically do better next time. And I think that might be provocative to the attendees of SCbio. They might say, well, what do you mean? We've learned so much. Of course, we'll do better next time, but not necessarily. I'll give the example simply at the outset of the pandemic, when CDC and Dr. Fauci thought masks were, probably not all that useful. Well, it doesn't matter how many times after that they said that they are. And they said we were wrong at the beginning. And there are reasons, virologists could tell you that a mask isn't 100% protective. But even this morning on a morning news show, I heard some people saying they don't know what they're talking about. First, masks were bad, now they're good. And we've got to understand that public health authorities are grassroots oriented. And so, we learn as we go. We use technology, but we've got to give public health a chance. Government can offer a guiding hand. The private sector can offer a lot of technology and other benefits, but we've got to let public health lead the next time there's a novel virus that comes our way.
I could not agree more. And the what I think has been most disappointing to me, I work and have spent most of my career at the intersection of health policy and health care. And when I have seen the politicization of a virus and people use it to advance a political agenda as opposed to trying to heal people and bring them back to health and prevent illness, it has been very disappointing to see that, just what you described, the fact that early on they weren't sure the masks were efficacious. So as soon as we corrected that, instead of moving on, we're going to make it look like people were flip-flopping and you can't trust anything they say. That's a problem. I'll just observe when I speak to different groups about healthcare and why America struggles so mightily with quote, fixing healthcare. I've boiled it down. I believe Americans want three fundamental things from their healthcare system, and they are, by definition, not all compatible with each other. Number one, they want the best healthcare in the world. Americans don't like the idea that some other country has better healthcare. Number two, we want somebody else to pay for it, right? Don't send me the bill for this. And number three, most importantly for this conversation, we do not want to be told how to live our lives. And you can see that. You'll remember the conversation about sodas and big gulps in New York City, and when the city tried to outlaw that, people freaked out about it. But here we see people saying, don't tell me I have to wear a mask. I don't want to wear a mask. You can't make me socially distance. You can't make me do these things. But the same people want their vaccine. They want to be first in line. It's very American, I think, to say I want everything. But it's very hard from a health policy standpoint, a public health standpoint, to accommodate all of those, to give the very best at no one's cost, and to let people behave however they want with impunity. So it is a challenge, and we'll continue to work on it. But Harris, I think you're wise to say, let's not assume we're going to make better decisions next time. Let's document the challenges we've stumbled across and make sure we do better next time. So let me transition us again. How can SCbio play a role in the reduction of health disparities? We've talked about health disparities as one of the most well illuminated failures of our healthcare system. What can we do to improve on that? Marjorie, you want to start?
Sure. I think that, SCbio just is a collaborator, right? And a connector. And I think really embodies that policy and that belief that if we can match research with public need and with industry demand, that we can create really a great model for elevation of socioeconomic status of those in South Carolina. And really that model would work globally. But one thing that we have seen during this pandemic, again, is that socioeconomic inequity also leads to inequity in many other facets of life. And that is something that I think really SCbio really touts, it lives, it's part of its mission and its vision. And so I see that as a real strength for SCbio.
Likewise. Courtney, you have thoughts?
I do. I think the conversation around equity is really a salient one right now. But I think to get at the heart of these conversations, that we really have to address sort of the elephant in the room, and that is sort of the deep distrust that runs in Black and Brown communities, not just of, the pharmaceutical industry, but the healthcare sector writ large. And a lot of that really reflects the systems of oppression that have occurred in communities of color, the historical record, and, sometimes in a lot of cases, painful stories that are passed down within families from generation to generation. So I think that is something that we all have to attack sort of head on, break down sort of these generational walls of distrust across the healthcare system, and act in a more transparent manner and really answer hard questions that are posed to us all along the healthcare ecosystem, and really work hard to rebuild trust. I think that's one thing that we're working on really hard at Pharma, particularly as we talk about, vaccine uptake in communities of color. I think we've all seen some data that suggests, folks are not necessarily maybe interested in taking the vaccine. They have some qualms. They want to know more about it. They really just want to have all the data to be able to make an informed decision. And so one of the things that our companies recently committed to in last year is we released some first ever principles on clinical trial diversity. So across our entire industry. And what we're really doing with these principles is having those honest conversations. So talking about building trust and acknowledging the historic record of mistrust around clinical trials that exist in Black and Brown communities, thinking about what we can do to reduce barriers to clinical trials to make it more equitable, really using real world data to enhance our information on diverse populations beyond product approval. and then enhancing information about diversity in clinical trial participation. So it's really important to keep all of this in mind as we go forward and have these conversations, whether it's COVID-19 related or just general health topics in communities of color. Those discussions, it's really important to try to find those opportunities to speak to those issues and to build on the unique partnerships across community and government.
Thank you, Courtney. Marjorie, when we did the prep call, you talked about your experience in clinical trials and that it's not necessarily a foregone conclusion that minorities and people of color won't participate. Tell us more about your experience.
Right. I think that one thing we did at the Office of Women's Health, which sits in the Office of the Commissioner at FDA, was to lead a national program around diversity in clinical trials. And that was racial, ethnic diversity, that was disabilities, lower socioeconomic status, age disparities. So diversity as a word really should connotate many differences, right? So one thing that we found in the research literature is that we, as researchers, and I'm a researcher, I'm an academic, a scientist, and a physician, and we sometimes assume things that aren't really borne out when we start really addressing it. So in clinical trials, it is interesting that although people of color might make up 40 or 50% of a population with a certain disease, that they may represent only 2% or 10% of a clinical trial. So when we get clinical trial data out, physicians and healthcare providers use that evidence in order to treat patients, right? So we want to treat patients. We want that equity in our delivery system and our therapeutics. But if we don't study the populations that are going to receive those medications or those therapeutics, how are we 100% certain that they are going to be equal in efficacy and in safety? And so I do want to give a shout out to the FDA. They have done a lot in health policy over the past 20 years, but we still have some more work to do. And I'll just echo Courtney in seeing the distrust around the vaccine and around the science. And just to remind everyone that this science the mRNA science around the vaccines, Pfizer and Moderna, did not just occur in 10 months. It was studied during the Ebola outbreak. It's been studied during the Zika outbreak. And so it's been studied for almost a decade to really reach this far. So there are, when we are leading a clinical trial, when we're a principal investigator, we need to think diversity first. And I think our pharmaceutical companies also need to demand diversity in their clinical trials. Thank you.
Sure. While you have the floor, Marjorie, you also talked in our prep call about the pipeline of physicians from underrepresented communities. Do you want to, since we're on that topic, you want to elaborate on that a few minutes?
Yes, one thing that brought me to South Carolina was this potential to partner with the largest healthcare delivery system at Prisma Health and also lead a very innovative medical school. A shout out to Dr. Pastides, who was a big champion for our school 9 years ago. But I will say that when we looked at, at where the pipeline is of physicians and students, undergraduate students, who really qualify to get interviews at medical schools and then get accepted to medical schools. I'm going to start nationally, Thornton, to say that we only have about 7,000 to 8,000 African Americans applying to medical schools nationally per year. We have 5,000 Hispanic Latinx. Of those, that number, small number, right? We have about half of that actually get accepted. So we have thousands of diverse want to be physicians that we are somehow not capturing and including in our incoming classes. In South Carolina, the data is disheartening. We receive about 575 applications from South Carolinians every year. We have 3 public medical schools, awesome medical schools in the state. We have more first-year seats for medical students than we have South Carolinians who qualify to come into those populations. And then you look at the diversity of that pipeline. So we have to reach back, I believe, not only into undergraduate, but I think the K through 12 to let people know that they can be physicians, to let them see themselves, to have mentors, to shadow, to have research opportunities. I think as someone who grew up below poverty in a coal mining town in Eastern Kentucky, told I would never be a physician, I think that we need to let our young people know that you can be a physician. It's not the color of your skin. It's not your socioeconomic status. Those are not limitations. And we have to create opportunities to break down those barriers. You can tell I'm passionate about that,
Yes.
right?
And I wanted to be sure we covered that. Thank you for talking about that. Sam and I will continue to talk about that as an opportunity for hospitals and SCbio to get the word out and make sure we're reaching into communities just as the universities are.
Thank you.
So, sure. So, Harris, we also talked about the state's health and prosperity goals when we talked about what SCbio can do to help reduce health disparities. Would you share your thoughts on that?
Yes, I will. Let me just piggyback for a moment, though, on what Dean Jenkins said, which is that the undergraduates who are choosing to major in health science or pre-med careers in South Carolina is at an all-time high. One might think that because of the frontline risks, they might have moved away. Not at all. If you talk to the medical school deans and the other health science deans, they can't even handle the undergraduate interest in, and so we've got to broaden the bandwidth, if you will, so we can get more of these qualified in-staters into med school and the other health disciplines. Relative to your question, the notion of taking care of our people and mitigating health disparities is not only the compassionate and the just and the moral thing to do, it's actually the right thing to do for South Carolina's economy. A workforce and a population that is ill, that is suffering from the nation's highest rates, for example, of diabetic amputation, which is almost always a failure of some part of the healthcare delivery system. We have stopped using the buckle of the stroke belt because we used it for so long. We're looking for more metaphors. But although we're lucky to have an influx of new corporations, I could tell you a barrier to recruiting headquarters and other businesses in all domains will be how healthy is the population. And so it's the right thing to do for South Carolina's economic future as well. It's not only a blue thing, it's a red thing as well. It's really good for everybody when the healthcare costs are skyrocketing because of the failure to prevent an illness. That is bad for everybody's pocketbook. And what I wanted to say as well is relative to SCbio and its ability to contribute to mitigating these health disparities. There's a moonshot going on right now in our midst, and it's called telehealth, sparked by the pandemic, and even increasing the bandwidth relative to K through 12, led by Secretary Spearman, Secretary of Education. We can use telehealth like never before for prevention, but also for early curative medicine and treatment. And I think there's a lot of technology that's needed. I would love to see SCbio team with its partners to ask how it could contribute, how the businesses in biotech could contribute to this. Let's make South Carolina the best, if you will, the best state in the country for deploying telehealth to mitigate health disparities.
That's very interesting that you talked about that. Our team was just testifying yesterday at the Senate about the fact that telehealth has really come into its own during the pandemic because it forced the use of the technology. Even people who were reluctant or apprehensive had to embrace it, and it's really demonstrated its effectiveness. So thank you all for those observations. So let me as we start to wind down, let me ask you what challenges and opportunities you see for South Carolina. Courtney, would you like to start us?
Sure. I think South Carolina, like so many other places in our country, has unique potential for growth. There are challenges there, so many that we've outlined here. But I think the opportunities for growth are around thinking about these gaps in access to healthcare, particularly in communities of color, how we can strengthen and bolster and really speak to the social determinants of health, where we live, where we work, where we play, and really put some policy structures around there to improve things there, because zip code really shouldn't matter in terms of your access to healthcare. I think Dr. Jenkins raised an excellent point about having a pipeline of physicians. I think that that's one of the issues and one of the challenges around issues of distrust, but an opportunity to really have folks engage in communities, come in communities as professionals, as doctors, as nurses, so that we have these lines of communications open in these communities, and folks feel like they see someone like them and they'll be more inclined to take better care of their health, be adherent to Dr. Harris's point, be adherent to their medicines, bring down costs, raise productivity. I think it's a win-win. So I think there are challenges, but there are many opportunities that we could take advantage of and make good use of.
Great observations. Thank you. Dr. Jenkins?
Sure, and thank you, Courtney, for cascading that messaging. I think we need to keep saying it. I will give a shout out as well to Prisma Health and our medical school, and that we've increased our diversity in our incoming class this year to a historic high of 26 out of 108 students. We now have almost 20% across 4 years. That used to be at a 5% low originally. People are surprised that a school in South Carolina can increase diversity, but we did it through intentionality. We did it through partnerships with Prisma Health, with our physicians of color, who help us recruit students, who tell students that we are creating a culture of diversity and inclusivity. And when I talk to students and to the public about what culture means to us, culture is something that you shouldn't have to think about, right, Thornton? It's something that it's like breathing. It's something that you have a value system in, you have a belief in. And so really creating that culture. And for South Carolina, I am so proud of South Carolina in that we are now in the top 10 of vaccine distribution. I think people often look to South Carolina as one of the unhealthiest states, but we have a lot of innovation in this state. We have a lot of opportunity for collaborations, and that force of SCbio and others who are creating those connections and collaborations are going to really elevate us. And for South Carolina to invest in our talent, we don't want to bleed talent to other states. We don't want to educate and then have people leave our state. We need to retain our physicians, our healthcare providers. We need to retain our biomedical scientists, our researchers, and our industry leaders to be in South Carolina and to really elevate the state, the population. And just as Dr. Pastidi said, and Courtney has said as well, is that really when we elevate in these other areas, we will elevate a population, we will increase compliance, increase access, and lower costs for healthcare delivery. Thank you.
Thank you. Okay, Harris, your thoughts about this question?
Well, just briefly, maybe to come full circle to your very first question, Thornton, about collaboration. South Carolina is a good size. It's well located. It's growing, but yet the crab pot mentality. We are about the size of some big county in Texas, and we can do much better than that. We really can afford to see our neighbor do well. We can afford to, take care of our neighbors a little bit better than we do. We're extremely regional, both politically, geographically. Our health systems need to do better as well, rather than fighting over patients. There are many, many examples of how they are working well together. But the research universities, all universities for that matter, the healthcare system. If we pull together a little bit more, it doesn't have to be a revolution, 5-10% better than we do now, we can make a huge impact. And I'm wearing my green sticker, meaning I was vaccinated yesterday at Prisma, by the way. And that makes me proud. But that's only one example of how South Carolina can be in the lead. And I do believe SCbio can be a very big part of that.
Well, I agree with you as well. I'll tell you that if I added my own observations, since we're in the middle and early phases of the vaccination effort, the vaccine hesitancy that Courtney and Marjorie talked about is a tremendous opportunity for a partnership approach. We have to convince the people in our state that they can trust this vaccine, and that it is better to take this vaccine than it is to take their chances with a disease that has really made many, many people very, very ill and caused untold death that we could have prevented had we had this vaccine on board earlier. So that's an opportunity, as well as reaching all the geographic corners of this state and all the populations of this state. That can't be done by any single organization or individual. It's going to have to be a partnership. So thank you for that. And Marjorie, to your point about innovation, I saw early on in the pandemic that the Prisma team up in the upstate developed a device called the Vesper device that would allow us to use a ventilator for more than one patient. And that was at a time when we really weren't sure this country had enough ventilators. And so that innovation, that rapid innovation, is a tremendous opportunity. And it was a life sciences kind of approach to solving a problem for the bedside caregivers.
And Thornton, I led the FDA portion of that, and we were able to get emergency authorization for the Vesper device within a few days. I think that spoke well and speaks well to how our FDA has really led as well in approving things that were life-saving at a time without all of the months of delay, which we didn't have at the time. And we met on Saturday. We worked 24-hour days. We had Salesforce involved in that. We had Hewlett Packard involved in that. We had University of South Carolina, Clemson as well, and Prisma Health, whose doctors really came up with the idea. And I just say, when you look at that collective, right, global companies coming in with academia and with healthcare delivery organizations and systems, that creates innovation and rapid innovation, which is really what we need. So we need to really start having a norm. That rapid innovation is what the expectation is, right? We need a new normal around that.
Right. You're exactly right. And we're going to get the opportunity when it comes to finding communities and finding ways to get in these remote corners of the state to vaccinate. Let me do the kind of the lightning round last question. As we prepare for future pandemics, back to Harris's point, let's not miss the opportunity to learn. Any thoughts on what we can and should learn from COVID-19? Harris, since you threw that out, anything else you want to add that's on the top of your mind?
Well, yeah, I think our audience here should know that the Duke Endowment is sponsoring a South Carolina and North Carolina Institutes of Medicine and Public Health review of what we can learn and what we could do better next time. That will focus on policy, and it will probably take a year. Obviously, we're still in the middle of COVID, but unfortunately, a novel virus will come our way again. And we want our state to be as best prepared as possible. So SCbio, working with the Institute of Medicine and Public Health, can go a long way. We've got to do better next time, and we will.
Thank you. Courtney?
I think what COVID-19 has taught us is the power of preventive health. So I think what we need to do better going from here is making sure that everybody has equal access to quality health care. And that includes having, those screenings that are so needed, those early screenings that are so needed, making sure people have a medication regimen that they adhere to, making sure they exercise and eat right and do all those things that we've seen, may have a detrimental impact on comorbidities with COVID-19. Because I think to everyone's point here, there is another pandemic coming, but if we can shore up those systems and, create ways that people can shore up their own health, we can do better in the long run.
Well said. Marjorie, last word?
Yeah, I think from the top down, from our public servants, our legislators, I know Dr. Fauci was talking early in the pandemic about masking. He was also trying to keep masks for those who really were at the front lines. That was another impetus for his statements in April. We all went to the grocery store and didn't see toilet paper for 3 months. Why is that? There would have been a huge run on PPE as well. I believe that our statesmen, our politicians, our public health officials need to lead with the science. I think always lead with the science, make that your foundation, and really try to understand what Harris has said about once people hear something they want to hear, it is very difficult to turn that off. And so the bastions of social media and digital media, the fear mongering and the misinformation, I think that's a whole nother evolution that needs to happen around accountability in that space, because we still struggle with that, and to the detriment of people losing their lives. I will just say a last word about the numbers of cases that we've had of COVID in the U.S., and we've had now 450,000 deaths. It will be the number one killer of people in the U.S. And we may get a little numb to that, right? We see the tally, keep driving, but each of those numbers represents someone's family, someone's sister, brother, father, daughter, son, friend. And so I don't know of anyone in my network that has not been affected in some way by COVID. And so I would just say that let's not get numb to this. Let's really take it as a learning opportunity. And when the next pandemic comes, let's take the lessons learned and do better.
Well said. So let me say thank you to the three of you, to Courtney, to President Pastides, to Dean Jenkins. This has been a very rich discussion. I really appreciate the insights that you have brought to the attendees and to not only SCbio, but also the Hospital Association. In our partnership, we'll continue to work on these issues. And with that, I'm going to go back to Aaron and Sam to wrap up the morning. Thank you all.